Well, good morning, and it's a great honor to speak with you this morning and about the role of radiation oncology in gastric carcinoma. I have really two goals with this presentation. One is to try to provide some context to the uses of radiation therapy in gastric carcinoma and the rationale for the treatment, and then to tell you how we plan it and what it's like, and show you how an actual treatment is designed and is actually administered so that you have a sense of what we're doing, and also comment on some of the newer approaches of radiation therapy that are much more targeted, focused, and critically treat the tumor well, but also critically protect or stay away from surrounding normal tissues so that some of the side effects associated with radiation therapy can be reduced and hopefully avoided altogether. So I would like to start with a case. This is a patient we cared for who is a 67-year-old patient with a history of a subtotal gastrectomy for peptic ulcer disease over 30 years ago, presented with bloody emesis, and was noted to have a 10-pound weight loss, and on endoscopic ultrasound had a T3 lesion, and on endoscopic ultrasound had no evidence of lymph node involvement, and in this situation had a PET CT scan, and you can see the FDG avidity within the gastric wall on this study. And so what are the options for treating patients with this particular situation? That is, they have a stomach cancer that is localized. It's not spread to other organs. And as Dr. McCarthy commented, there are a number of strategies. One could approach this with surgery first, followed by additional treatment. One could give chemotherapy before the surgery. And also, there has been interest in the use of giving radiation therapy and chemotherapy before the surgical resections, and there are pros and cons of all of these. An old study now, but actually a very important study in that it set the ground rules, if you will, in the United States for adjuvant or after treatment. And this was a study run by the cooperative groups in the United States that took patients who had had surgery and randomized them to observation alone, no further therapy, or post-operative radiation therapy and chemotherapy. And at that time, the radiation therapy was relatively simplistic in how it was administered. So just to give you a sense of what we refer to as the volumes that are being treated in this setting, you're treating where the surgery used to be. Importantly, you're treating the regional lymph nodes. In the setting of a subtotal operation, you'd be treating the lymph nodes remaining in the stomach. You'd be treating the the central lymphatics, the celiac, and along the periortics. In the case, you're also trying to cover the resection margins, and some additional regions are treated. And these are very general guidelines that were used to care for patients. One of the challenges of this particular study was that the surgery was found not to be optimal. About half of the patients had a limited operation of just resecting the tumor without an extensive lymph node tumors. And what this study showed was a statistical improvement in the outcome of patients receiving adjuvant radiation therapy and chemotherapy. And as we've heard this morning, many of our survivors had followed this guideline or paradigm of treatment, and 10-year data continues to show the effect of the value of post-operative radiation and chemotherapy. And the principal reason of the gain in outcome for these patients receiving postoperative treatment was that the failure rates in the local bed or in the nodes was reduced compared to just surgery alone. And this translated into an improvement in outcome. Now, there's been, in some ways, a follow-up study to this US trial from Korea called the ARTIST trial. And this trial took, again, patients with resected stomach cancer. And this time, they weren't, the arms were both treatment arms. One arm received postoperative chemotherapy, the other arm received both chemotherapy and radiation therapy. And here's a look at the particular volume, if you will. You can see a radiograph of the abdomen, and in yellow is the field, the radiation field, and within that box, if you will, is the area that you're treating. You're treating the lymph nodes, you're treating potentially the margins. This is a pretty simplistic field arrangement as well. And this is what was treated in this particular trial. And the results of this trial did not show any advantage, if you will, to the addition of radiation therapy combined with chemotherapy versus the patients who received only chemotherapy. But the trial did show that in subgroups of patients that there appeared to be an advantage or a suggestion of improvement with radiation therapy and chemotherapy. And the one to note was the presence of positive lymph nodes. And so for that particular subgroup of patients, it certainly could be considered. And a very recent analysis from this study looked at the patterns of failure of where the tumors came back in the two groups of patients. And the picture to the right shows that in the patients who received the radiation therapy that there was a marked reduction in the lymph nodes recurrences. So that in this particular trial, as well as in the cooperative group trials, these were where the gains were. And the Korean investigators are now looking at a follow-up trial looking at patients with lymph node positive disease to establish its validity. Now, I'm sure Dr. Ilsen, and I'm sorry I had to step out when Dr. Ajani was speaking, and Dr. McCarthy did comment on the value of perioperative chemotherapy for patients with resectable gastric carcinoma, and I'll leave that for their discussions on. And there are ongoing studies looking further at the uses of radiation therapy for resectable rectal carcinoma. There has also been, and I think importantly, an interest in neoadjuvant radiation therapy combined with surgery. And there are clear advantages of neoadjuvant chemotherapy and radiation versus adjuvant in the sense that the treatment is better tolerated, the radiation fields are substantively lower, and the efficacy, at least in other disease sites, appears to be positive. And this is one Chinese trial that looked at gastric carcinoma that showed an advantage to a preoperative approach. Dr. Ajani, many years ago, led a study from the RTOG that looked at preoperative or neoadjuvant treatment. And these are just some preliminary results saying that the approach was tolerable and a potentially feasible strategy for patients. There are randomized trials looking at neoadjuvant treatments ongoing. This is one from Australia evaluating. What I'd like to go over now with you is how do we actually care and utilize and plan our radiation therapy for patients with gastric cancer and a number of malignancies. For patients undergoing gastric radiation, they're treated they undergo a process that's called a simulation. They're asked to lay supine on a treatment couch. They have a device that places their arms up. We ask them to be NPO 3 hours before treatment. We also assess the amount of respiratory excursion that a patient is having during the simulation to see whether or not motion management has to be taken into account. We utilize what's called a 4-dimensional CT scan to see whether we need to gate the radiation with respiration to ensure target coverage. And the patients receive oral and IV contrast. And after the simulation, we plan the patient, and based on imaging and all the data from the endoscopies, endoscopic ultrasound, we take that CT scan from the simulation and define the target to receive treatment. So it is a very very individualistic patient treatment for patient by patient. It is not in any way a cookie-cutter approach for our patients. The location of the lesion is critical in deciding what lymph nodes need to be treated, and the series of anatomical diagrams, the upper left shows a proximal lesion, what lymph nodes you'd be treating, and then the diagram to the last one to the far right is a distal gastric carcinoma, and these aid us in planning our radiation fields. Now, there's been a lot of heterogeneity and with radiation oncologists in terms of their ability to plan these treatments. And to help radiation oncologists, we've established what are called CT-based nodal contouring atlases. There are available now to radiation oncologists atlases that define the relevant anatomy to educate and ensure that across the United States in community settings that the treatments become more appropriately defined and targeted. So this is based on nodals and the areas that need to be treated. And we go through careful planning, deciding how much of the surrounding normal tissues need to get treated. Small bowel, the kidney, the heart, the liver, because as our patients survive longer, if these organs are not protected and spared from the treatment, the late effects can become quite serious, requiring interventions, be medical or surgical. And we've learned a great deal in the last several years about the normal tissue tolerances and what ways we can develop to spare these organs from radiation therapy. This is an example of a 3-dimensional plan that a colleague of mine treated at Duke. In pink is the esophagus, and green, that's the hatch marks, is the stomach, you can see, and then the surrounding yellow is the radiation field. The kidneys are protected, only a small portion of the liver is treated, and a number of fields were used to treat this particular patient. And so very careful attention to this patient's anatomy was used. More recently, there has been interest in what is referred to as intensity-modulated radiation therapy. And to explain it to you, as a cartoon is illustrated here, we have on the left what's called a non-IMRT beam. And you see the radiation dose going through the structure in the center of it in a very uniform way. And on the right, the IMRT beam, with this particular technology, one is able to modulate the radiation beam and turn it into essentially beamlets, if you will, with varying doses. And this allows you to even more precisely conform the radiation to areas that are to be treated. This is a patient of mine that's actually on treatment right now. who has a gastric carcinoma that is receiving intensity-modulated radiation therapy. The upper left screen shows an axial CT, then there's a coronal section, and then a sagittal section through. This is a highly conformal treatment with much improved reduction in dose to surrounding tissues. Fortunately, this patient is moving through treatment uneventfully. So, can I go back one? Yes. So to go back to our case, the patient underwent, had a PET scan post-treatment, underwent gastrectomy, and is disease-free from 1 year from surgery. I think that the new areas that are being explored right now are using the techniques of intensity-modulated radiation therapy, but as I'm sure Dr. Ilsen will speak about, a lot of tremendous interest in novel agent combinations with radiation therapy, including well-known antibodies such as trastuzumab in HER2-positive patients, and also the new immune checkpoint inhibitors, which are now being looked at in investigator-initiated early phase 1 studies with radiation and gastric cancer. Thank you.
Thank you, Dr. Willett. I'm going to open up for questions. We have one here close to the front.
Two questions. If you're going through a series of radiation treatment, you'll go through maybe 5 days in a row for 4 weeks at a time. And on Monday, Jane straps you in. Tuesday, Bob straps you in. Wednesday, Sarah straps you in. And they all have different degrees of strength and tightening to put you in the right position. So I always wondered, am I in the right position? All right. So my question is there somebody watching where that radiation is hitting me and would be able to adjust if it wasn't at the time hitting the right spot?
It's a very good question, and the answer is yes. I'll have to tell you how we would approach a patient receiving care at our institution for gastric carcinoma. So at our institution, the linear accelerators where patients receive the radiation therapy are positioned supine, often in a not necessarily strap. That has sort of they're placed usually into a cradle or an alpha cradle or some device that immobilizes the patient. And so that's step one. The radiation fields that are to treat the area that needs to be irradiated are determined by specific anatomical landmarks from the planning session, if you will. That's number two. After that positioning is done, number three is actually all of our linear accelerators now have very good image guidance. In other words, you can visualize the area to be treated in two ways. One is these accelerators now have diagnostic quality imaging so that you can validate the internal anatomy. And then in addition, routinely, what is called a cone beam CT or a CT scan on the accelerator is done that verifies three-dimensionally that the area that needs to be treated by cone beam CT is verified, so that the treatments now are extraordinarily accurate. When you're using a technique like intensity-modulated radiation therapy, one has to be absolutely sure that the area that you need to treat is radiologically and defined with millimeter precision. Otherwise, by the nature of the physics associated with these types of treatments, you may begin to miss the target, and that, of course, is unacceptable. So a lot of progress in validation. And then for some patients, the treatments require what is called gating. You only want to treat during a certain phase of the respiration because sometimes the soft tissues can move up or down based on the respiratory cycle. So there's now technology available to allow us to actually treat during a limited phase of radiation to again validate with these very conformal treatments that we're treating what needs to be treated.
Okay, we have a question online. This is more from a diagnostic perspective. It says, why, when doing CTs, do they not do full body scans? For example, if you have a stage 4, why not see if it has spread to the brain or it's a cancer not one to spread to the brain?
Well, I think in the initial evaluation of a patient with a gastric carcinoma that we do routinely image the chest, the abdomen, and the pelvis. We do not, unless there's a specific symptom or hint that there may be involvement of the CNS, to image by MR or CT the brain. It's fortunately a less common area where these cancers can spread to.
Okay.
Yes.
I have a question right here.
So my daughter had a spot on her liver and metastasis from gastric cancer and had 2 weeks of radiation. And the follow-up PET scan revealed that the spot was still there. But then an MRI was ordered, and the MRI showed that there were 2 spots. So at first we were concerned about that, but then the team at MD Anderson said that those spots could be scar tissue from the radiation in January, and we need to get another MRI to evaluate. My question is, we have not used the MRI that I know of in the past. It's usually been a PET scan. So why would the MRI, what does the MRI show that's different, that would lead to a different conclusion? Because originally with those 2 spots, I was hearing talk about possible liver surgery. So what is the use of the MRI showing? Thank you.
Sure. The MRI is often used to further clarify or characterize abnormalities that one is seeing on CT scan and PET CT scan. It's a very complementary type of study, and by the nature of the imaging that's done, one can determine scar tissue, as you've commented, potentially tumor involvement. In some situations, you can determine whether there's blood vessel formation by an MRI scan. So I would say that it is a complementary study to the 2 studies that your daughter has undergone. That's about as far as I can go without looking at the images myself. And I'd be happy to do that if you'd like.
Just as an addendum to that, the MRI will be used with a special contrast material.
Correct. Right.
There's a lot of commercials about something called the cyber knife.
Yes.
For cancer patients. What's the difference between that and radiation and people with gastric cancer?
So CyberKnife, it's a marketing tool, to be candid. It is a specific technology that gates the radiation treatment to motion and respiration. All of the current vendors right now have similar capabilities, if you will, of motion management to target the radiation, say, to a gastric cancer, taking into account the respiratory motions. CyberKnife is simply a specific vendor that has this capability as well. So it is a device that employs radiation therapy as other vendors as well.
How does that differ from a gamma knife?
A gamma knife is a device that's commonly employed, uses cobalt sources, actual radioactivity, that's targeted and is frequently given for patients who have disease within the brain. It's a very high dose of treatment that is given for primary malignancies within the brain. Again, it's also a vendor and principally limited to CNS disease. There are now devices becoming available utilizing these very high, using this type of technology with cobalt for ablative and high dose treatments. A separate vendor though.
Is the CyberKnife used on bone or just soft tissues?
Is it used on what?
Bones.
Yes, it can be used on any anatomical site.
And it, because also it's very precise. Like I've had radiation and it was a wide area. Is the CyberKnife more, or takes in a smaller area instead of damaging a lot of area?
I think that the CyberKnife, as well as any modern technology from the vendors, is able to treat very small areas to very large areas, such as 20 by 20 centimeter fields. Again, I want to emphasize that the CyberKnife is simply a specific vendor for a linear accelerator that has the capability of taking into account organ motion, which is good, but there are other vendors that have technology that has the same capabilities.
Another question. After radiation, let's say of the liver, what is a safe period of time to then go in after that for surgery?
Well, there has been, in the last 5 to 10 years, tremendous progress in a technology that's called stereotactic body radiation therapy. And it's a treatment approach in which one uses stereotactic techniques and very high doses of radiation and very specific imaging to confirm the fact that the area that's to be treated is in fact being treated. And for patients who develop a limited number of hepatic lesions, 1, 2, 3, or perhaps 1, 2, 3 lung metastases, one can use stereotactic body radiation therapy and typically administer somewhere between 3 to 5 treatments over 2 weeks. It's an ablative treatment. One is giving a very high dose of treatment. And the data so far would say that the control rates are excellent in the areas that are being treated. But one has to really be using this particular technology in the context of the overall treatment plan for a patient, be it surgery, be it combined with systemic therapies. The stereotactic body radiation therapy continues this treatment. Its effects and changes in the liver takes months to evolve, and imaging shows really quite a range of views of the tumor as well as the treated liver over these months. I hope I answered your question.
Well, suppose it's not successful.
It's not metastatic?
It is metastatic.
It is metastatic. Okay.
Suppose it's not successful. Not successful, he said.
No, it is metastatic, and if the radiation is not successful, I'm asking, what is a safe period of time to wait for a surgery to occur after that?
I think that an operation can be performed. I think first I would step back that if a patient has a hepatic metastasis, I think many would recommend that the patient be considered for a resection or an operation if this could be done and judged to be with curative intent as the first step. Oftentimes we're asked to consider stereotactic treatment when a hepatic lesion may not be potentially amenable to surgery. Your question as to when the surgery can be performed, I would expect probably 6 weeks following the treatment. But I would, myself, if I was asked to care for a patient, would have a discussion with the surgeon to fully understand what areas the surgeon was to remove. I think that potentially when one is using such aggressive forms of radiation treatment, that if one is trying to put together anatomy and normal tissues together, if it's been in tissues that have received these very high doses of radiation, they may not heal satisfactorily. So it's important that there's a good discussion between the radiation oncologist and the surgeon in that particular setting.
Okay, I have a question online here. It says, in what circumstances, if any, would radiation be used in a metastatic cancer that has spread to distant lymph nodes, but also what about liver and lungs?
I think radiation can be certainly employed, can be used to help patients that have specific symptomatology from disease, for example, involving the lymph nodes. If a patient should develop a lymph node disease in the neck, for example, radiation can be employed to shrink the nodes and relieve the patient of pain or other symptoms associated with that. If the situation arises, a patient has cancer spread to a bone and there's pain in the bone, radiation is very effective at relieving pain in the bone from that metastasis. The other situation that sometimes happens is that a patient has stage 4 disease at presentation, and there's tumor in the stomach and there's bleeding. We often consider radiation in that particular setting to shrink the tumor and stop the bleeding and get the patient onto systemic therapy. So there are a number of approaches to help patients with stage 4 disease, and those are a couple of examples.
Thank you. We have a question in the back.
So you had mentioned 2 different clinical studies, one that was performed in the US versus one that was performed in Korea. Those, as you probably know, that there's a big difference between the anatomical site as well as the histological appearance of those cancers, US compared to Korea. And you showed that the treatment was effective in the US population, but it was not as effective in the Korean population, who has more of a non-cardia diffuse type of cancer. What's your take with regard to treating patients based on histological appearance or anatomical location using radiation therapy?
Well, I'll just try to clarify a little bit some of the caveats to the trials, and it's a good question that you asked. One is that there was an advantage, well, the Korean trial overall did not show an improvement in the disease-free survival, and that was all comers of the patients with gastric carcinoma. That would be patients who received adjuvant radiation who were both node negative and node positive. But interestingly, in that Korean trial, about 85% of the patients had evidence of lymph node involvement. They did a subset analysis, which is strictly hypothesis generating. It wasn't designed in the trial in its initial format. And in that subset analysis, they did show an improvement in the outcome of patients with node-positive disease receiving the adjuvant therapy, but it's a subset analysis. And they're now going on to a phase 3 trial looking at node-positive patients. In the US trial, which was also took node-negative, node-positive, one of the biggest confounders to that trial was the fact that half of the patients had a very limited surgical resection, so that in fact they really did not have the extent of lymph node resection that the Korean trial had. That mandated in its design a D2 resection, which was extensive lymph node dissection. So we're a little bit, in some ways, the American trial is a little bit different in the sense that it did mandate that we're limited to such a high percentage of patients with limited resection. So I think those caveats are actually pretty important in defining the difference. Clearly, your question is relating to the potential biological differences between the Asian population and American population, and that's a clear difference in the one of the subset analysis between looking at intestinal variant versus diffuse involvement. The biggest gain in adjuvant treatment was in the intestinal subgroup of patients. So there are clearly biological differences, as you've indicated.
Okay, we have a couple questions online. As a follow-up to the last question that we asked from an online person, it says, my question is actually, no, please ask if radiation can be part of a curative approach in the case of possible restaging when there is a complete metabolic response to chemotherapy.
So let me make sure I've got this straight. For this patient, the patient has received systemic chemotherapy and then presented with localized disease or stage localized disease.
Yeah, localized. The last question was it went to a distant node.
So it's, well, certainly I think that if a patient who has, I guess, stage 4 disease is treated with systemic therapy and has what we're hearing is a very good PET scan result, no metabolic activity in these distance areas, what do you do? I would assume that I would recommend that the patient continue with the therapy that is helping this patient in this situation.
Right, yeah, I agree with that. Another question, it says, stage 4 has been controlled, then a Krukenberg tumor develops. Would radiation be appropriate?
So I think in that setting, then, it may be helpful for palliation if there's evidence of disease that has spread outside the stomach area, if there are symptoms warranting that treatment, such as pain or evidence of obstruction.
Okay, great. Thank you so much. You know, one of the things that we're going to do is we have a little time allotted and would really like the speakers from this morning to come to the stage and just answer general questions that we may have on the topic. And since Dr. Ajani is not here, please, David Ilson, if you can field some of the questions. And I'll start off with the first question. Any of the other speakers from this morning, please come to the stage. Well, I'm going to follow up with one particular question that came up. It says, and this I'll have this for Dr. Ilson, is EOX appropriate choice for stage 4 cancer, 10-centimeter tumor?
Yeah, not really any longer. You know, EOX, standard chemotherapy for stage 4 disease usually combines a drug called 5-FU with a platinum drug. So that could be 5-FU orally using a drug like Xeloda, or it could be 5-FU infusion through a Metaport. Platinum drugs, we usually use cisplatin or oxaliplatin. The British have typically added this third drug, epirubicin. So that's the E in the EOX. And there's more and more studies suggesting that that drug only adds side effects to patients. Because the 5-FU platinum, you know, either Folfox, 5-FU oxaliplatin, or capecitabine oxaliplatin, is pretty well tolerated. You know, patients don't lose their hair. and side effects like fatigue and nausea are pretty manageable. You add this epirubicin drug and patients have hair loss. You have hair loss, you have mouth sores, it can be toxic to the heart. So increasingly, we're trying to discourage practitioners from using EOX, this epirubicin drug really adds no benefit beyond 5-FU platinum, and we don't want to subject patients to side effects of drugs if there's no benefit. The British kind of dug their heels in with this, but if you look at recent controlled studies that compared 2-drug chemotherapy to 3-drug chemotherapy, there's no benefit. So I feel like that's actually a question I feel very strongly about. So I would say no to EOX.
Thank you, Dr. Ilsen. I have another question online. It says, if the cancer is HER2 positive, what are the odds that your children will get this disease?
Well, I could take that
Yes,
one.
Dr.
I saw a preview of the coming attractions. I have a slide in the talk that I'm giving that really kind of touches on this very issue. And really what it gets to the point is when we talk about the genome or DNA in cancer, there's 2 different ways to think about DNA changes or DNA mutations. So we all have the DNA that we inherit from our parents. For each gene we have, we get 1 copy from our mother, 1 copy from our father, and those copies can be quote unquote normal, or they could have some differences, and some of those differences can impact your risk of getting cancer. Now, beyond that, when we talk about DNA in the context of cancer, most of what we talk about is the way that the cancer cell has DNA, where the cancer cell's DNA is different from the cells of the rest of our body. The cancer has acquired mutations, meaning the changes in the DNA. And HER2, when cancers are HER2 positive, that is this latter situation where the cancer cell changes its DNA. The cancer gets extra copies of the gene for HER2, but that's the way that the cancer cell is different than the cells in the rest of the body. So in that situation, what you're dealing with is a gene change just in the cancer, not the rest of the body. So in that situation, the kids would not have inherited that HER2 gene. So that's the simple answer is we have to sort of separate the genes that we inherit from our patients or from our parents, which could influence cancer risk. But most of what we think about with cancer genome is really the way that the cancer cells are different than the cells of the rest of our body. And whenever the cancer cells are different than the rest of your body, that means you're also different from the cells that make the egg and the sperm and go on and get passed on to your kids.
Great, thank you. I have a question for Dr. Willett. It says, when a gastric adenocarcinoma is metastatic in proximal and distal lymph nodes, would radiation rather than resection be the next line of treatment if there is a dramatic chemotherapy response?
You certainly could consider radiation therapy for treatment of lymph nodes, and that in the setting of lymph nodes that are in a region. If they're diffuse lymph nodes, for example, lymph nodes in the neck and then lymph nodes lower down in the periortic region or into the pelvic lymph nodes, it's not clear to me that it would be advantageous in that setting. So we do consider radiation therapy for treatment of lymph nodes, but it's usually in the setting of treating a very well-defined region, not diffuse regions in different parts of the body.
Thank you. I have a question for Dr. Ilsen. My wife has stage 4 stomach cancer, and she's 1 year into treatment, and she's been maxed out on FOLFOX and now is on irinotecan and ramucirumab. Is there anything more aggressive or effective that can be considered?
Well, more is not always better. Patients always ask me, hit me with your best shot. And more is not always better with chemotherapy. So, FOLFOX or 5-FU platinum-based treatment is the best initial chemotherapy. And if that stops working, we usually go to Taxol or to irinotecan-based treatment. And we use this new drug that Dr. Johnny talked about, ramucirumab, which significantly improves the effectiveness of Taxol in secondary treatment. More is not better, so we tend, after combined chemotherapy initially, to use single chemotherapy drugs later. If you make treatment more intensive, you get sicker, and it doesn't always improve outcome. And as you get more and more treatment, you don't tolerate treatment as well. So you have to balance aggressive treatment with effectiveness, but also to maintain quality of life for patients, because more is not better with chemotherapy. We learn that over and over and over again.
Question in the audience?
Well, if there's no history of cancer in the family, what, in order of importance, would you say are the external, environmental, and lifestyle habits that could develop into cancer?
Well, we think 30% of cancers are tobacco-related. So we know that. I mean, if smoking disappeared, we would see 30% of cancers disappear, and that would include lung cancer, a significant amount of lung cancer, bladder cancers, kidney cancers, and there may be an association with breast cancer and GI cancers. So I think that's a key lifestyle factor that could be modulated. Environmental factors, I mean, we just don't know. I mean, there are certain occupational exposures like asbestos and mesothelioma, and certain workers in dye industries, or they're exposed to chemicals. They may have increased risk of blood cancers and bladder cancers. But the environment does play a role. A lot of it, we think, is just kind of a roll of the dice. As we get older, our body accumulates mutations, and some of these mutations never amount to anything, and other of these mutations and changes lead to precancers and ultimately cancers. So smoking cessation, probably a lower fat diet, more of a Mediterranean diet may be beneficial. That may reduce colorectal cancer risk, breast cancer risk. Obesity in the West has complicated the epidemic of liver cancers, because we get this fatty liver syndrome, that metabolic syndrome that may increase the risk of liver cancer in appropriate settings. So, hope I answered your question.
Mm-hmm. We have a question here in the front, but in the meantime, there's a question. It says here, is there any testing you can do, and what kind of testing to determine how at risk your children are? Maybe Adam, that's a question for you.
So that's, it's a good and complicated question. So we have an rapidly exploding capability of doing testing, of studying the genome of, there's a lot that you can do. The problem is that interpretation of that testing is extremely complicated. And I think what's fair to say is, well, first, there's a whole field of people who work in genetic counseling who really can help people deal with these questions. But I would say is that there are certain situations where there is more reason to pursue such testing. So, clearly, when people have multiple family members who have cancers, when cancers occur at younger ages, there's stronger reasons to think about these issues. What then is usually useful, though, is to start with the patient who has the cancer, to see if the patient has some change that could be hypothesized to be a contributor. And in some cases, there are gene changes that are really slam dunk obvious. For example, there is a form of stomach cancer, diffuse stomach cancer, for which there is a variant which we call hereditary diffuse gastric cancer, where there's a particular gene change, a gene called CDH1, which, if it's lost, can clearly give people the risk of that cancer. But if you don't know what's happening in in the patient with cancer, then it's often hard to interpret what's happening in the family member. So I gave the example of CDH1 being a gene that, if it's different, can put you at risk of diffuse gastric cancer. Now, I bet if we just went around this room and we sequenced everyone's DNA for the CDH1 gene, we're not all going to be exactly the same. Just like we have other gene changes, which is why, you know, we all look a bit different. We're different heights, our ears look different, or what have you. You know, we have a lot of variation in our DNA. So there's even variation across the population of people in CDH1. So if you just took people at random, a lot of them would have a CDH1 gene that looks a little different than the average. But what that means is hard to say. So, so that's where it could be challenging. And so sometimes if you don't, you know, what that could mean is that, you know, you could, doing gene testing when you could lead to people getting false alarms and saying, oh, I have this variation in this gene CDH1, and so people will get really nervous and think they have to get endoscopies every year, or maybe they don't. The other thing that can happen is that because we don't understand all of the genes that can contribute to cancer risk, is you also could be falsely reassured. You could say, well, okay, we know about CDH1, you know, I got sequence for CDH1, it's normal, but there could be something else that's present. And then so you could falsely reassure yourself if you just look at one particular gene. So it is very complicated, but, and again, that's why, you know, we have people who are trained as genetic counselors ready to walk people through this, and that's why you kind of, when you get the testing, you know, you work with a counselor who could help you think about the implications. You don't just, you know, do it at, you know, CVS on your own, because there's a lot of things to consider.
Thank you, Dr. Bass. We have a question in the front, please.
I'm a stage 4 cancer survivor, inoperable. And my question is, once a person is on a regimen that works for them and they become NED, because I'm not seen at a high volume center, how often does that return to that type of cancer, that person? If you're stage 4 and you're NED, and then, you know, my doctor says it'll return, he just doesn't know when, and mine is never shown on any scans at all. It was only shown through surgery. You know, they went in to remove the stomach, but they found much more because PET scan, CT, it doesn't show. And they mainly go on my symptoms as to whether, you know, it's returning or not. And my question is, in the patients that you all see, how often does that NED person become, you know, with active cancer cells again?
Well, everybody writes their own book, and that's one thing you have to learn, you know, because when I talk to patients that are newly diagnosed, you just don't know what the future is going to hold, and you have to be hopeful and optimistic. And there are patients, clearly patients with stage 4 disease that get remissions with chemotherapy. I mean, it's usually partial remission in most patients, but we sometimes do see complete remissions. I can't really quote you how often that lasts or how long it does, because it's uncommon for patients to have complete remissions with chemotherapy. It does happen. I have patients in my practice I'm treating. It also depends on how you document it. I mean, there are some patients that PET scan is not helpful for everybody. And just to follow up on a question earlier, PET scan should not be used for screening, and it should not be used for follow-up. It's an expensive test that generates false positives. And the only time that we use PET scan to follow patients with stage 4 disease if the CAT scan doesn't clearly show things. But PET scan is not preferred here. It should be done for staging, and then it really shouldn't be repeated. So there are some patients that their disease does not show up on scan. What I also would want to do is make sure that an endoscopy was done to document that the local tumor is not active. My practice, when I have patients with metastatic disease they're on chemotherapy, I usually continue the treatment because it's working. I'm always reluctant to stop chemotherapy in stage 4 disease because those complete remissions are not always durable. And unfortunately, probably in most patients that have clinical complete remissions, the cancer does come back. That seems to be the case. But there are some patients, again, people write their own book. They're on treatment for years and years. You know, I saw a patient in my clinic last week I'm treating since 2007 that's free of cancer and still being treated.
How often are the scans?
I've gotten to the point I'm only getting a CAT scan on him every 4 or 5 months.
Thank you.
Thank you. I have a surgical question for Dr. McCarter. So its question is, for stage 4 that has been controlled in lymph nodes and stomach with FOLFOX, now a tumor developed in her right ovary while on the FOLFOX, would she then be a candidate for surgical ovectomy?
Well, so that's a good question, and it's commonly asked is, does it make sense to go remove some other areas that might pop up later on? And in the vast majority of those, the answer is it doesn't make a whole lot of sense to do so, because it's kind of like, you know, the first snowflake in a storm. You see that one, but there's, you know, hundreds of those elsewhere that you can't see. And so technically, yeah, you could remove one spot, but there's going to be a whole bunch of other areas that you can't address with an operation. That's not to say we don't do it. There are certain times when we do it. And some of that's dependent on the symptoms of the patient, but some of it is also dependent on the biology and the timeline. And there are some patients for whom we can achieve good disease control with other therapies, whether it's, you know, systemic treatments or radiation treatments. And then there is one spot that can't really be treated any other way. We will occasionally go after that with an operation, but we're very selective about who that is. And so as a rule, I wouldn't say it's commonly done, but it's a possibility, and it's one of those things that it's best sort of vetted in that multidisciplinary group. When, you know, we get together with our colleagues, as Dr. Johnny was saying, you know, it's the whole team gets together and kind of weighs all the pros and cons of those, you know, being surgery or radiation or what other treatments might be available, and then try to make the right decision for that patient.
Thank you, Dr. McCarter. We have one more question here in the front, and then we're going to have lunch. Oh, then we have another one over there.
This question is an attempt at clarification on the radiation question, and I will address it to the whole panel. Somewhat simplistic, but again, looking for clarification. My understanding is that the MAGIC study, to a large extent, has become the standard of care for operable gastric cancer. And that study indicated chemo, surgery, chemo. So I'm still unclear, and I think many others are, on the real role of radiation in gastric cancer treatment.
Yeah, I think Chris highlighted this, that it seems that radiation may be required when less adequate surgery is performed. The US trial, the standard of care for surgery for gastric cancer is a D2 resection. And in the American trial that showed a benefit for radiation, 10% of patients had a D2 resection. I think that chemotherapy is clearly part of the adjuvant, you know, either before or after surgery. I honestly don't think it matters whether you get the chemotherapy before or after surgery. I think that patients tend to tolerate it better when you split it before and after surgery. And I'll show the data later. If you look at the outcome from all these approaches, the benefits in terms of survival are the same, regardless of what treatment you give. Just to comment on that Korean trial, where everybody got a D2 resection, and then half of the patients got chemo alone and half got chemo plus radiation. In all comers, there was no benefit for the addition of radiation. Also, if patients had a diffuse cancer, they had no benefit. Patients who were node negative, they had no benefit. And in the patients that were node positive and intestinal, the benefit was pretty tiny. It was about 4 or 5%. So the Koreans are now repeating a study where they're targeting the patients that most likely will benefit, but it's not likely that radiation adds a lot if you've done a D2 resection. And people that get surgery in the community very often have D0 or D1 surgeries, and, you know, the surgeon took out 4 lymph nodes and 2 were positive. That would be like the person that was treated on the US trial that benefited from chemotherapy and radiation.
Thank you, Dr. Ilsen.
Well, I have to give an editorial to Dr. Ilsen in this setting. So I think David's comments are all very, very appropriate. There is ambiguity about the efficacy of adjuvant radiation therapy. It is being looked at in the Netherlands in a very, very good trial with good surgery, which has been one of the challenges that we've seen in the US trial that will actually compare. It's the so-called critics trial, looking at patients receiving chemotherapy with or without adjuvant radiation therapy. So I wouldn't be quite so dogmatic as saying that it has no role at the present time. It's being studied.